Cherene, Cherene, if you can, add to your introduction and kind of lead in, and I will help monitor questions and comments.
Thank you so much, Vesper. Coming from you, those sentiments really hit me deep. When somebody who I really respect and admire says beautiful things like that, I really I'm humbled and I'm grateful. So thank you for that. I also am pleased that you kind of said preemptively, especially where these things are existing, when these ecosystems are coming up, because you and I have had a lot of conversations about what it's been like to build these alternatives in the South. I live in North Carolina, and when I came into the state, peer support did not exist in North Carolina. There was no CSX history of the movement. People were Googling recovery around mental health when I would talk. They were Googling peer support. So we literally had to start this from the ground up, which is not an easy thing to do in general. And it's really not an easy thing to do in a Southern state. We were the first peer-run organization in the state of North Carolina, independent peer-run organization, particularly in the mental health space and community. And it's been an interesting process to see this take hold and figure out what we can do to strengthen this movement in our state, certainly, but then, of course, across the country. And so what I was asked to do, I recently, I think it was last year, did a series for the Family TAC. And the links are out there for each of those presentations. But what I decided to do is break down examples of standalone peer-run organizations and these alternative models and present them. Bit of an awareness. What I was asked to do for today is something very similar, to take all of those models that I presented them, collapse it into 15 minutes and present them here. And so if everybody's okay with that, then that is what I will do. But I will also stick around for chat, dialogue, and questions and things like that. So does that work?
Absolutely. Yeah.
Let's do it. In some ways, I feel like when I do this stuff, I'm a little bit preaching to the choir, but then I realize that for a lot of folks, these things are new, which is blows my mind. So anyways, I'm going to talk about different alternatives. These are not all of the alternatives. These are just a handful that I wanted to highlight today if we get through them all. As alternatives to incarceration, involuntary treatment, confinement, coercion, and the use of police. You'll see the examples. We're going to talk a little bit about warm lines and respites and peer-run wellness centers. I want to talk a little bit about diversion, which is a bit of a controversial thing that I'm going to present, but that's okay. And as well as psychiatric advance directives and non-police community response teams. So we can't go in depth in any of them, but at least I'd like to skim some of those. So I am the CEO of Promise Resource Network. We are an alternative to traditional treatment for people in our community that have experienced very complex trauma and expressions of trauma that have been labeled with a combination of mental health, substance use challenges, houselessness, or former incarceration, that are uninsured or underinsured, although most of everything that we offer is open access. So it doesn't matter, it's irrelevant if a person has insurance and not. But a lot of the folks that we see are folks that are uninsured, and the majority, which is interesting, are folks that have been kicked out of services. So a lot of the people that we work with at our peer-run organization, people have been involved in services, they were kicked out or they were opted out because they felt harmful. We currently operate 16 different programs. This is just a listing of what they are. We are opening, as we speak, 4 new programs. We are designated as both a COSP on the mental health side and a recovery community organization. So we are one of the few organizations that has both designations. And some of the new programs that we're starting or projects that we're starting are supporting people coming out of adult care homes. We have a lot of kids, 30 kids have been boarded in our emergency department for 160 days or more, living in 1 bedroom. So we're starting an initiative around that. We're also starting a sober bar and a recovery cafe. So just a couple of examples. We were talking about trailblazing, starting up new things and doing it in real time with community. I do want to make a quick differential between peer operated, peer staffed, and peer integrated. They are very confused, at least in the circles that I'm in. people think if you employ peer supporters that it's called a peer operated agency or it's a peer operated program. And so I'd be remiss if I didn't say that everything we're going to talk about really falls under the first bucket. That is these standalone organizations that are independent from behavioral health organizations that are staff led and have board leadership of people with lived mental health experiences, that all decisions are operated by the staff independently. And for us, we use a fidelity tool called the Facet, which I'll talk about in a minute. That is to be differentiated from a peer run program. And those are programs that operate underneath behavioral health agencies, and they may have program directors and staff that are peer supporters, but I call those peer run programs. And then you have peers integrated into behavioral health, where you have a behavioral health agency that runs a program that employs peer supporters, but all of the authority, the leader, and finances sit with the agency. A couple of things that what I find that most peer run alternatives have in common, obviously they're survivor led. That goes without saying. We often use some sort of fidelity. For us, it is the Facet. We are often open access or low or no barrier access. So everything I'm going to talk with you about today is an open access space, meaning for us, no referrals are needed, no insurance are needed, no assessments are needed. There is nothing that is needed for you to engage in these alternatives. It is truly come as you are. They're non-traditional ways of engaging and supporting people that is completely not non-clinical. Sometimes they're used as enhancement to services if a person chooses. Sometimes they're used as completely alternative. And we have a trauma-informed recovery paradigm, which means that we do zero involuntary force or coercion in any of the programs that we operate. If you're interested in the Facet, this is just to give you that visual. A Facet has 46 program items. I think it's pretty decent. I would update it at this point, but it's a good, if you're looking at starting a standalone peer run organization, it's a good tool to help guide some of the content that you have and the way you're structured. So let's start with the peer run warm line. There seems to be some confusion about peer run warm lines. Peer run warm lines are
at the end of those questions, but I do want to give you a chance to bring up that.
Okay, we got it.
Got it.
All right. So peer run warm line is I'm defining it as an all peer run organization, not a clinical agency that hires a peer workforce to run the warm line. So this is a standalone peer operated warm line where all of the team members, including the leadership, have lived experience. Non-emergency support, obviously the difference between emergency and non-emergency, most everything else falls within a non-emergency support other than the person is at physical risk or physical danger in the moment. Everything else falls under. That means that people call for all different types of reasons, from thoughts of suicide to distressing voices to I'm feeling isolated and alone, so I need some support in problem solving. The hours and the days of operation vary. Ours is 24 hours a day, 7 days a week. So it's a pretty intense in terms of operation. Oh, I'm sorry, I'm hearing somebody else. And the purpose, of course, is connection. And, you know, we started our peer run warm line when our state went on lockdown, never imagining that we would end up with 65,000 callers in the year and a half of COVID. So it's a very heavily utilized line. We are completely prevention and diversion from hospitals, 911, as well as mobile crisis units and mobile crisis teams. So I'm so sorry, I have a dog yelling in the background outside. So we do not involve these type of first responders, including mobile crisis teams, unless it is something that the person themselves say that they want or need. Everything here is very transparent in our warm line. And then warm lines exist in 40 states, and you can get the directory there. This is the visual of our warm line. We have a lot of information that we could share about the peer and warm line. But just know that it started during COVID, but it was so successful that it continues now, way beyond COVID. The second one that I want to throw out and share with you is a peer run respite. I know that some of you have been talking a lot about peer run respites. A peer run respite for us is completely voluntary. It is completely not forced or coerced, which means, and these nuances are really important, it means that we do not allow the conversation about you either go to the emergency department or you go to the respite. That is coercion. It has to be completely voluntary as a respite stay. It is short term for us. People can stay for up to 10 days overnight. And it is in a home in the community. It is non-clinical. It operates 24 hours a day, 7 days a week, and it is unlocked. Except for, just like anybody's house, you have locks to your home overnight. And then there are locks on people's bedrooms. Like when you go to a hotel, people have a key fob and they can choose their own code and they can lock themselves, everybody else out of their bedroom. Some stays are 2 weeks, some stays are 10 days. It just really varies. And the cost differential between an inpatient stay and a respite is really quite astounding. A couple things about our respite. It is staffed by 2 people with trauma histories that identify psychiatric survivors who have been system involved or experienced extreme states on every shift. And they are specially trained in addition to peer support in trauma, in emotional CPR, when the conversation turns to suicide, and intentional peer support. We utilize the fidelity for the facets. And we see crisis very differently at a peer-run respite. We don't think of crisis as a liability and a risk. We think of it as an opportunity for us to explore who we are in our experiences and expression of distress. It is trauma and healing focused. It is not pathology based. We do not focus on illness, stabilization, or behavior management or modification in any way. The paperwork is minimal and the imposed structure does not exist for us. We also do not use clinical language. So we do not use diagnostic language. We don't use symptom language or any other frame of reference or worldview that is rooted in a clinical paradigm. And we have no staff only spaces. We have no staff only spaces. So everything in our respite is communal. We do not handle people's meds. Medications is a personal decision. And as we say, medications are a tool. For some people, they feel helpful, awesome. For other people, they feel harmful, awesome. And then we do not manage any type of money. All power imbalances are avoided at all costs. So for us, our guests can come and go. They can maintain employment, school, family connections. People check in and check out at our respite at different times, but checkout is at 11 o'clock. And I'm just going to show you a couple of pictures. So the outside of our respite is as critical as the indoors because we want spaces for people to heal and come together. So we have a lot of water features and plants and just different ways for people to experience environment with the respite. What we took out of and put in the space is very intentional and is very critical to having an environment that feels like it's healing. So we have really designed it for comfort and beauty and gathering and beauty, in breathing. Everything that we have chosen, from the colors to what is in it, was designed around the way we heal from trauma as human beings. We have 2 living rooms. These are pictures of our living rooms. When people come into the space, usually they do a couple of things. They look around and they say, oh my gosh, this is beautiful. And then they go to a bedroom, whatever room that they want, and they cry. And here's the reason. When you walk through the space, it is very beautiful. It's updated. And every guest gets their own bedroom with a queen size bed, their own refrigerator, a white noise sound machine, Wi-Fi, lockbox, whatever it is that they want or they need. And a lot of times people come in and they say, I'm not on a cot on the floor, or I don't have to share this room with 2 other people. It is unbelievable the way we fund, what we fund, and how we are treated at times of emotional distress and crisis, where people come in and they cry because they have their own bedroom. It's shocking. And then this is just some information about the respite. I do want to point out what I have on the bottom of it. No one is allowed to be dropped off at the respite. Police, family members, service providers. It is completely voluntary and non-coercive. We have had 2 incidences at the respite since we opened. Both involved guardians. And in both situations, while the person said they wanted to be there, it became clear to us that there was a level of coercion and pressure that was involved in that situation. So how we operate the respite is critical to people coming and feeling like it's a healing space. The third alternative, and you all stop me when I need to stop. We don't have to get through all of it. The third alternative is what I'm calling a PRN wellness center. It's a slightly different from a drop-in center. It is open access. We now with COVID have about 95 different classes and things going on every month. And it is a hybrid of on-site and virtual. If you're interested in our most recent calendar, you can go on and take a look. But we try to bring in things based on the 8-dimension wheel. And so we bring things very specifically in that balance out the 8 dimensions. So if somebody is really on a spiritual path to well-being, that there are things that resonate with them. If somebody's interested in financial literacy or they're focusing on their physical health and well-being, we have things like that. We also do some, we try to make it interesting and fun, right? So like instead of doing an anger management class, it's how to unfuck yourself. Is a class, or we have a class that's called How Big Is Your Butt? And that is, well, I want to work, but I want to go to school, but I want to move out of the group home, but, and so we teach you to identify how big your butt is and then butt reduction techniques. So we try to do these things in a way that also feels really engaging and accessible to us as a community. This one is a little bit controversial. And when this was brought to us, my original response was absolutely, we're not going to do this. But our team members that have been incarcerated or have been involved in court systems actually were the ones that said, no, we need to do this. And so we are actually involved in 5 specialty courts in our community, which means that we do a few different things. Number one, we support the person that is going through the court process to know their rights, know their options, and support them around healing and wellness. We also are involved in every legal staffing and every clinical staffing. For every court, there are 2 staffings that happen twice a month. So it's very intensive. And people don't realize in these courts, decisions are made in these staffings. They're not made in the court by the judge. They're made way ahead of time. So if we are not in these spaces where those decisions are being made and we're challenging conversations around criminogenic thinking and somebody, just is non-compliant and expecting that sanctioning is okay. If we're not there to disrupt that, people are ending up in jail and prison. As a matter of fact, when we got involved in these specialty courts, there was about 20% of the people that came involved that ever actually ended up completing a wellness court or recovery court. The rest of them, 80% were ending up in jail. And now it is more like 80% that are completing wellness and recovery courts. And, to a person, they say that the role of a forensic peer supporter or peer supporter with lived experience is the reason why the culture is shift in that environment. The next one, and I only have a couple more, is a psychiatric advance directive, also controversial. And this is my disclaimer around the psychiatric advance directive. We do not have good policy in most of our states to make a PAD legal and binding, meaning that even if it's a legal document, there's a lot of policy that gives wiggle room to hospitals and clinicians to not have to honor and validate the psychiatric advance directive. In saying that, I use this as an alternative because we have been successful in, if somebody's PAD, their preferences are not honored, then it becomes a rights issue, which can become a legal platform, right? So having a psychiatric advance directive is very personal. For me, I would rather have one and not need it, or have one and them not respect it, but it be in writing and be in a legal document that this is what I had said, does not work for me. These are my preferences. This is what is harmful. I would rather have it and have it documented and not honored than not have it at all. It's controversial. Not everybody agrees with that, and that's okay. A psychiatric advance directive is really an opportunity for people to have rights in their psychiatric medical treatment if they were to be hospitalized, particularly if they were to be incapacitated. There is a difference between incompetency, which is a legal argument and a legal issue, and incapacitated, which means that I literally cannot voice what my preferences are. A psychiatric advance directive goes into place when somebody has a capacity issue. And then it is not a RAP plan. So people get confused between the difference of a psychiatric advance directive and a wellness recovery action plan. Obviously, if somebody wants to add their RAP plan to their PAD, you can absolutely do that, but a RAP plan is not legally binding. And so oftentimes in different states, there are requirements for a psychiatric advance directive to be recognized, and it has to be in a legal document or some sort of form or format, then gets notarized and gets signed off on. There is, if you're interested in the PAD requirements and the legal documents and the policies in your own state, you can go to NRC PAD and look up your own state. And then the last one, I told you all this was going to be quick, right? This was like a series of 7 different sessions that we did over an hour and a half to 2 hours. But the last one that's getting a lot of traction and a lot of attention is non-police community response teams. I am so glad to hear that this is a groundswell around the country to have the police out of the response. Dan Fisher had said in an earlier session that he only knows of 1 or 2 that are completely peer run, peer staffed, and independent. We are seeing a lot of co-responder models. So a clinician and a peer supporter, or a medic and somebody with lived experience, or a social worker and a medic. So many do not have peer support is a part of it. But we ended up doing an evaluation nationally of non-police community response teams, gathering the data and making 17 different recommendations in our state to fund non-police community response teams, and it ended up being funded. A couple of our recommendations were this. These are teams that are by community for a community that have a level of diversity of lived experience. When we talk to people in our community, this was a direct quote. We do not want clinicians in white vans and officers in Black uniforms in our neighborhoods. There is a very strong response to mobile teams that are clinically driven. That it needs to be designed, led, and staffed by completely diverse communities in terms of racial composition, ethnicity, gender, sexual orientation, people that have experienced houselessness, incarceration, gang involvement, in addition to lived experience and mental health. That we're talking about diversion from confinement, shackles, handcuffs, and involuntary treatment, but the question is always diversion to what? Right? So we fundamentally in our community, the police are absolutely on board and they're champions for non-police community response team. They want to know diversion to what? And that is where the keynote today and the alternatives conference comes into place. We have to have more of these alternatives so that when we're making the arguments that we need to divert away from carceral care, we have options that we have already in our community of diversion to what? And we were proposing nonviolent, non-criminal calls, welfare checks as well, that these are mobile teams, meaning they don't just get dispatched, but they are in community by community. So they are going to the community neighborhood picnics. They are doing backpack drives and clothing drives and handing out food. They are fabric of that community. They're not just being dispatched in when there's a crisis. There has got to be neighborhood relationship, trust, psychological safety, and physical safety set up for a mobile crisis team like this to be successful. And then, you know, we kind of kept getting stuck on, is it dispatcher 911? Is it dispatcher 211? Is it completely independent? I'm a person that believes that all access is good access. There are people that will call 911 and there are people that will absolutely not call 911. So if we remove it from an option, there are people that won't have access. If we only use it as an option, there are people that are not going to have access. So we have to find these access points where people are comfortable engaging. I talked about the diversion to what, which is a lot of the models that we talked about. And then we had a strong legislative role in this. We had to put together, we ended up putting together 3 bills with non-bipartisan support around gathering data around involuntary commitment, as well as funding alternatives to confinement, as well as funding these non-police community response teams. So in a nutshell, That was, I don't know, 20 hours of what we typically talk about, but that's a little bit of a smattering.
Quite excellent. Thank you, Cherene. And I think at this time, we'll move into just questions, initial reactions, thoughts, applause as well.
You're my hero.
You're ridiculous. You sat through every single one of those, and yet you're still here with me today. It's good to see you, Jim.
Ditto.
Real quickly, Vesper, before you also move forward, many of you are asking about, getting copies of slides and videos. I think they're going to get collected. Judine, I know you're on here real quickly. Can you give an idea about when people might begin to see these?
If you all just email any presentation you have to info@ncmhr.org, it will be on the alternatives website faster than we can get a drink of water.
Oh, hold up. I'm not beginning to show. All righty. Thank you. I know that's coming up again and again and again because it's so good and you want to get your hands on it. So that way you've got the person here, Judine, who's going to let you know. Go ahead,
There
Judine.
also is already a link there to Cherene doing a 5-series webinar on these different services too. And I think there's at least one link for you, Vesper. Anyway, yeah.
And those are much more in depth. If you're interested in any of these individual topics, they're actually broken out per session, and you can go back and take a look if it interests you.
Awesome. Thank you. Back to you, Vesper.
Thank you. I think it's great information. It's good to have an archive and, to keep building this work collectively. We need that archive, right? So I see Heather, Rhea, and Tova. I'm going to start with Heather.
Hi. I had a question. Is there anything in place for people who are in mental health incarceration? Like, is there any kind of, whether it be national or state, like someone like in the hospital that you can go to? Because I know, like, when I was put in patient, whether it be voluntary or involuntary, they supposedly had a patient advocate here or there, but that was useless because they just went back to your psychiatrist or your whatever, and it still didn't matter because if you didn't take your medicine, you didn't get to get out anyway. So it was basically useless. Do they have, like, I mean, they have patient rights and everything. Like when you go to, for medical purposes, they have that. Where is that in place for somebody who's thrown into a mental health facility? What, especially when it's against their will? Like, is there anything for that anywhere yet?
So I can start that answer, and I know there are several people on this that can answer from their own state and their own experience. Here's what I would say. Yes, however, for me, it's more important of a question to say, is there anything in place that actually has teeth, right? That has power to stop or to remove the use of confinement, or to actually do something when people are harmed in hospital settings and harmed during the process of involuntary commitment. I've seen a lot of spaces for people to make complaints. Some of them can end up in litigation. So like disability rights is an example that can end up in litigation. I'm not seeing a lot of things that actually have teeth, but I will tell you, I was a part of a mind freedom conversation last night in something called Judy's Room. And that exact issue came up, and somebody that was there saying, gosh, we need something like a line or something that people can call, but it can't be co-opted. And I didn't respond because I was doing a couple of things, but my response is there is nothing that prevents us from organizing and developing a phone line for people that are confined in psychiatric hospitals, for loved ones, whomever, to call and to report these violations. And then for us, independent of systems, to do our own investigation and finding ways to influence it, whether it's through legal means or others. There's nothing that would prevent us from doing that. So I just throw that out there as we're talking about alternatives and we're talking about trailblazing. What would it take for us to design it by us, for us?
Yeah, that's basically kind of where I was at, because I know out of my own history and own story, like the numerous times I did go because of restraints or because of whatever's, and like I went and complained, and I literally got left in longer because of the complaints, and it didn't matter. And that is still a practice at our local like hospital for, and when you said about the, it resonated 100%, because I think about how many people, I work in a mental health facility, outpatient mental health facility, and like it just blows my mind how people refer to mental health people who are in and out of the hospital as frequent flyers. And that totally, because I know, I'm sure in somewhere in my own, I've used it at one point, and that will never occur again. And thank you for that, because we go through the trainings and we're going through the how to speak appropriately with people and how to approach it. But yet that's something that if we're continuing that, how are we helping in any way, shape, or form?
It's that we're validating it. We're saying it's okay. It's okay to refer to us in these demeaning, derogatory, and harmful ways. And not only is it okay, but I do it too. So it's not a big deal, right? So that's part of the problem of that. I do want to say, Heather, that Jim Godstein had put a link to an, oh no, gosh, you don't have to apologize at all. Jim Godstein put a link to an article that they'd written that talks about this particular issue. And then Rita had said that in New York, which I love how New York does this, there's like a secret shopper that can go into psychiatric hospitals unannounced and have conversations with people, and people can call them in or they can go in unannounced. You know, it'd be interesting to know, Rita, how much influence that ends up having on the practices that are used around seclusion and restraint and involuntary treatment and harm in hospitals. But the fact that you have that is pretty damn cool.
Thank you.
It's an excellent reflection. And I do want to say that there's also the Mind Freedom Shield campaign, right? And Jim Godstein also does a really great job with the Mind Freedom Shield campaign when we get alerts from a Mind Freedom member that's in the hospital. But we could build up our volunteer base, and we are looking to crowdsource and fund the Shield campaign, because it's helped so many people try to get out of these institutions or fight for their rights while they're in those spaces, right? So I'm going to drop the links to those as well. And I see Ria, you have your hand up.
She's down in the comment box. She'd like you to read that.
Oh yes, thank you. So not sure if I missed this information. I'm at work and have to step away sometimes. How many people can stay at the peer respite you showed in the presentation? Where does the funding come from? Are there zoning issues in locating something like this in a residential neighborhood? Also, does your community have peer mental health drop-in centers? We have lost so many of our drop-in centers in our state and locally. Also, you are amazing. I am so freaking inspired.
First of all, I love the fact that you use the word freaking. So I don't know who you are, but I'm already a fan. In terms of the respite, so our house, it's a 4,000 square foot house. It actually has 9 bedrooms in it. It has 3 kitchens. It has 6 bathrooms, 3 living rooms. I know it used to be an old Airbnb that was divided into 3 different Airbnb units that we opened up. In saying that, we have 3 guest rooms that we use for the respite. The reason for that is we do not want it in any way, shape, or form to feel like a group home, to feel like a congregate living space. It is a retreat. It is a space for us to come. If there's a lot going on in that space, the reason why we're looking for those small spaces that are quiet is that we can heal and we can think and we can engage in our own process and with other people and with different things. So we have intentionally kept it small. So 3 people can stay up to 10 days. That obviously can be requested for longer if needed. The funding for us is completely local dollars. So our local community pays for our respite. Our annual budget is $550,000 a year for the respite. It is in a residential neighborhood, and there were zoning issues because for our area, because we had less than 5 people, it didn't have to be zoned as a service provider like a group home or anything like that. It just needed to be zoned for residential as well as business. And we're very fortunate in where we're physically located. We are in a mixed use zone. So it is zoned for both, but zoning becomes an issue, right? Before you purchase a property or rent a property or lease a property, you need to know what the zoning issues are in your community. Oftentimes there's no zoning specifically for a respite, right? It's not like you can look up what is a PRN respite zoning. So you have to play around with it and figure out what most works in your own community. Do we have drop-in centers? We have our Peer Run Wellness Center, which is the closest that it's a drop-in center in terms of anybody can come at any time. It has more activities and things going on than what a drop-in center would be. So there's a lot of classes and groups, everything from African drum circles and African dance to using different scents and different juices to support groups going on and educational things going on. The mammogram bus comes every quarter for both male and female and non-binary identifying folks to have free mammograms. We have HIV testing and STD testing on site. So it's more than what I think a lot of people think of a drop-in center. It's a very active hub is what we like to call it. Great questions.
Well, thank you, Cherene. It's comprehensive. It's a great response. And it really, again, I think really shows that building of a, community healing continuum, right, within all of these things.
Completely.
Tova, I see you have your hand up.
Hi, yes, my name is Tovalea Toodleman from Los Angeles, California. I identify as a Jewish woman who's part of an international organization for Jewish women who are either identify with mental health challenges or family members of those with mental health challenges, and there is some convergence of some of us having mental health challenges and being family members thereof, myself included. And I just booked a meeting for this evening with the founder of my organization. And Cherene, thank you very much for your presentation at this meeting. Thank you, Vesper and Cherene, for your presentation earlier today, and to everyone who presented yesterday, whether it was in this action meeting or in the sessions before the action meeting. I have gained so much. I have so much to discuss with my founder now, because we've basically been working via Zoom, via phone meetings, some in-person things, not here in California. As I said, we're an international organization Yes, we are. Yes, we are a 501c3 here in the United States. So it's just, I've been, so like the two of us, the founder and I, have been throwing around different ideas of what we'd like to see. And Cherene, I cannot even, I can't even imagine what, if we had the funding, if we managed to get the funding and not have to deal with all the bureaucracy, that what we could possibly do in bigger cities. I personally had wanted to take the Medi-Cal peer support specialist training here in California. I'm going for my GED because I want to get into that training, because I can't get into that darn training without it. And if anybody has any suggestions as to, since I have some peer advocacy work under my belt already, having been a volunteer in ILC and whatnot, because I really want to start working to help the women internationally, and especially women who I know locally here in Los Angeles have not picked up and said, yes, I could use this peer support. And I don't even know if the training is necessary. But I'm just saying, I'm learning so much. This is my second year here at Alternatives. And thank you to the lady, I'm not sure if she's on this particular call, who introduced me to Alternatives last year.
Thank you. Oh my gosh, you're amazing. I can't believe you're involved in all of those different things. And I didn't realize that there was an association or group of people that identify as Jewish and either in the family space or in the psychiatric survivor space. That's amazing.
And where some of us are actually psych patients and identify as psych patients, some as psychiatric survivors, like we have the whole gamut. Cherene, I will be in touch with you. Definitely, definitely, definitely. And
Okay.
I did leave my email address somewhere in the chat if anyone wants to get in touch with me, because I wasn't able to copy down everything.
Thank you.
Okay, thank you for letting me share all of this.
Yeah, this is fantastic. I'll certainly be reaching out to Tova. And the reason why is like, I my ancestors were crypto Jews, and you know, I've been learning a lot about my my family's roots and a lot of different things, and it's so intertwined. And when we think
Yes.
about psych survivors, also a lot of the leaders and a lot of folks in our movements were also Jewish as well.
Yes, and this particular organization serves women only, but there are other organizations that I know of that serve both men and women, in mostly in separate groups. But yeah, so anyone who wants to reach out about the Jewish, what the Jewish community has, and yeah.
It's perfect.
Thank you.
Thank you for everything you do. And I'm wondering, are there like more remarks and reflections just on what we've spoken about, like one, that intersection, but also kind of like this weaving of, I guess, our own systems? Because when we talk about abolition, we inevitably build our own systems, even if we dismantle something. So I you know, a lot of these ideas, right? Or just any more general comments or questions on what Cherene's presented on, which is a lot of comprehensive, excellent stuff.
Well, I have a question. Well, first of all, that place was absolutely gorgeous that you showed. And what I thought about was how, if you would look at it at first glance, because, you know, no one would have a clue that this would be for the rich and famous, right? And that it would cost, you know, 5,000-10,000 a day, kind of rich and famous, right? And so there is that access, and to know that the cost is what, $150 a night, is just mind-blowing, especially when you look at it as a hotel charge for, you know, if you can get a hotel right now for $150, man, that's just incredible. and you're definitely not going to get it for that type of luxury of what you just shared. But even though that's so huge of being able to offer a beautiful space, a healing space for that, there are still people that, you know, can't afford it, right? As much as, you know, many of us would say, well, that's a incredible price for $150 a night. What do you do with those folks? How do you accommodate?
Oh,
the
I'm so
people
glad you
that
asked that question. So we don't charge for it. It's completely free for people. That's the cost to run it, right? So if we were
Wow.
to take a look at the cost of an inpatient day, which when I wrote this up, it was $2,100 a day in our state. It's now $2,500 a day. So the cost of an inpatient day for somebody versus the cost of running a respite is $150 a day for us. So the person is not charged. Everything for them is completely free. As a matter of fact, we give them a $50 gift card to a grocery store when they come in, so they can have any preferred food. We stock the kitchen with staple items, and then people have the gift cards to have to go out and get preferences. What we find is a lot of people will take their gift cards, like guests that are staying at the same time, and they'll go shopping together and then create communal dinners and family lunches and, you know, all those sort of fun things. But yeah, there is zero cost to a person to stay at that respite. And you're right, it is beautiful. One of the conditions for us in starting the respite is it needed to be funded well enough to be in an environment, a community that felt safe, and a physical environment that when you walk through the door, we respect you, love you, and value you enough for you to be in a safe, comfortable, beautiful space, right? That's all part of the experience of healing. And, you know, part of the hope is if people come in and they're living, you know, some people come in and they're living on the streets, and they come into a space like that. And we've had several people end up saying, I'm ready to be in a home again, right?
Oh.
Just after being in a bed, in a bedroom, in a home environment. So yeah, the physical space was key for us.
And I know you had a limit on 10 days. Do you have a waiting list? Because you know, I know you have a lot of bedrooms, but in comparison to how many people probably need this space of healing, I'm sure you've got to have a waiting list.
Yeah, we're in an urban area. We could easily have 5 respites just in our city alone. And it be full all the time. You know, this was our demonstration. This was during COVID. Honestly, this was the argument that I made during COVID. You haven't listened to us for all these years about having alternatives to emergency departments and confined spaces. And now we have the coming together of racial injustice that has been going on forever. And people saying, wait, why are police responding to folks in a mental health crisis? You have a public health issue where emergency departments are shut down to anybody that doesn't have a COVID-related medical issue. You have inpatient units that are having to either people stay on the unit or they're discharging people, and you have lawsuits around the use of confined spaces during COVID. This is a perfect storm that if you had built out alternatives on the front end, we wouldn't be sitting here in this situation now. So perhaps now is a time for us to have these alternatives so that we're prepared next time, and we have another way to support people that doesn't include emergency department boarding, use of police, and inpatient setting. That was my argument that got us the respite.
Wow. Thank you for sharing that. Thank you.
Yeah.
For sharing that.
And that house is the first building we purchased. Up until that
Wow.
point, we leased for 15 years. So that was our first actual purchase, and it happened in the middle of COVID.
I love it. So many wonderful things happened. As bad as it was,
I know.
There were a lot of incredible ideas and creatives and businesses that were born from COVID. So bravo again to you for that.
I want to ask a question, actually. Did you have any challenges in terms of renting or purchasing space? Because I can tell you that for us in Massachusetts, for our Caraco Peer Respite, we had so much challenges in terms of just finding space, people who would rent to us, right? Or sell to us, depending. So I think part of this too is like that's the challenge when we talk about challenging some of these social ideas, because like we're trying to
Yep.
have a space like this, right? And
Yep.
it can be hard. So yeah. How
So
about
it's interesting with the respite. So now we own two spaces. So one is a 5,000 square foot space where our hub is moving into in a couple of months. And the other one is this respite space. And then we lease a little house next door to our respite. So that's like a 1,500 square foot house. The respite and the house are in a neighborhood. And, you know, I was concerned about that. Frankly, this is the first thing that we did is we drove around the neighborhood and counted up how many Black Lives Matter signs and how many pride flags there were. Because that was a condition for us. If you're going to call the police because there's a Black man with dreads in the neighborhood, we're screwed, right? Because at any given time, that is going to be the majority of the people that work there. So we looked around the neighborhood to try to get a sense of the type of neighborhood that it was. And it was clear that it was, you know, we're in a southern state. So I'm going to say this, it's all on a continuum, it's all relative, that the neighborhood is a little bit more liberal, right? But then we had to try that out. And so we reached out to our neighbors and their response was, when it was an Airbnb, there were so many fights and police being called to that house because of what do you call it when a person is getting married and bridesmaids and what's that called?
Bachelorette parties.
Thank you. So the police were being called because of bachelorette parties at that Airbnb. And there were a lot of fights, and they said people were very disrespectful of their neighborhood with trash and things like that. So when we came in and we started beautifying the space immediately, they were all in. So when we have a Juneteenth celebration, when we had our open house, when we do open mics, our neighbors are involved in it. They'll come and just sit on, we have a couple of different areas where people just can come and sit. Our neighbors will come and just spend time there. So we were very fortunate in terms of that. In saying that, we're in an urban area and space is very difficult. We had to move our hub from that 1,500 square foot space because it's just too small for what we need. So we found this a very rare find, 5,000 square foot building in the middle of the city that cost $2.75 million, right? We're a peer run nonprofit, but those are the prices that is required. So we have to be very good with the business side of the work that we do and the administrative side of what we do so that we can compete in a market like this.
Thank you for that comprehensive response. So powerful, so important. And, you know, I'm thinking about like also opening a peer respite at the height of COVID, right, as a response. And it was interesting for us when we opened. We started in a hotel on the 5th floor. And then we moved into a house because we were able to find a house eventually. And we also had complaints and a few other things. But it was interesting because the hotels were all empty at the height of COVID. So they needed the business. So it was a good local collaboration as well. So I just think in terms of action, when we're thinking about how we can build a lot of these models, these are just some of those ideas and some things to be thinking about.
Mm-hmm. Vesper, I've got a question, and if you all don't mind, it's an anonymous question. This person would like to ask, is there any sort of vaccine requirements to be there? How is the COVID precautions policies handled in such a mutual living space?
That is a great question. And you know, I also welcome other respite examples. We do not require vaccine to come to the respite. We are very intentional about making sure that spaces are cleaned, that, you know, during COVID, we were doing temperature checks and just the whole 9 yards. We were requiring people to have a negative COVID test before they came into the space. It's become more lax than that now, but we do pay attention. Obviously, if somebody is not feeling well, coming to the respite is not going to be good. People still wear masks. That is personally decided, but the respite also is cleaned throughout the day, several times a day. It was much more stringent during COVID. Some respite shut down during COVID, which shocked me because I thought if there's any time where we need the respites, now is the time. But there was a lot of fear, right, about coming into a physical home. So I get it. But we didn't shut down during COVID.
Yeah, thank you for that. And you're right. Fear really was leading many people in all areas, right? Thank you for that. And the person said, thank you for answering as well.
Yeah, it's really, really important when we think about the fact that everyone in our movement, right, more largely, whether or not they want to be vaccinated and engaged, they should still have access to these resources. So like, you know, for us, we also do testing. That's really just been an important piece, especially just at the height of COVID as it rises and comfortability levels and all of that. But I do want to open the floor to other questions pertaining to peer respite or any ideas that we want to think about, because we want to also come out with like tangible actions. I'm very interested in the court models that Cherene was talking about, and some of those pieces, like how do we implement some of these things on a statewide level? I know that it's important to and on a local level in general, it's important to advocate and speak to our district attorney, because you can make a lot of changes there. District attorneys hold a lot of power, people, like on a local government level. And I'm wondering, like, what was that process like? Is there any wisdom you could share for other folks who are thinking about this?
That was one of those things that was concerning me, right? We are a non-force, non-coercion human rights organization walking in the middle of court process. So the least human rights focus, and I'm like, I don't know if this is going to work, but we need to at least try to figure this out, because our community was saying, no, you guys need to be there, right? Something has got to influence the way this is being done. Our DA was our biggest challenge in terms of that's not true. There were two different groups that were the hardest to convince. The DA, who is now our biggest champion. As a matter of fact, in our last SIM mapping session, the DA got up and said, I was not a fan. Not only was I not a fan, I was against the use of peer support in these court proceedings. And if it were not for the use of peer support, we would not be where we are at today. It has got to be in every court process. So our DA's office became one of our biggest champions.
Skip.
I'll tell you the biggest challenge that we still have today, the treatment providers. Because we are in a wellness court talking about things like harm reduction, talking about things like psychotropic medications being an option, but not a requirement, talking about harm in the name of treatment, talking about healing, cultural relevancy, not focusing on behavior, shifting language. So part of what we do in everything that we do with the courts is we do a lot of training for the magistrates, we train all of the judges, we train the public defenders, the DAs, the treatment court staff, the treatment staff, parole and probation officers, on a whole series of things related to well-being, healing, and recovery. Fortunately for us, the results have been so great that when we got over that first hurdle of people being very hesitant, now they keep asking for more and more of this and less of treatment, quite honestly, which, you know, is music to our ears. So yeah, it's been a whole process. We've been doing that work for probably 8 years now, 8 or 9 years. So it's been a minute.
Wow.
I should have said, Vesper, we are the one resource involved with people in courts that is completely voluntary. You cannot court order peer support. So that was one of those things. It was one of our, you know, I said we were very values driven, and there are compromises that we can make, and there are other things that we will not compromise our values. Going into it, we said we will never be a court ordered, mandated anything that is completely conflicts with peer support. And to this day, we are the one thing that is not court ordered.
Very impressive. And you know,
And
that,
the one thing that works.
and the one thing,
Go figure, Jim.
yeah, I'm wondering, do folks have any other thoughts and questions? I see some questions in the chat and some reflections as well. I see one particular question about this idea of like where we're trying to get clinics to contract for peer services with peer-run organizations. Any tips on how to get started? That one was Rita.
I love that question, Rita. So here's what I will tell you. In several of the programs that we operate, we do the peer support piece, and we are co-located, or we are working with other team members from other organizations. Again, I hesitated about that. Like, how connected to systems and services do we want to be? What I did not want them to do was hire their own peer supporters and it up, right? And so we decided, let's try it and see if it works. Hallelujah. I am so glad we did. And this is part of the conversation with SAMHSA, is if we built up standalone peer-run organizations to do, I don't know, peer support, and then those peer supporters are actually doing the peer support component of what they are paying clinical providers to do, that we have something there, right? Instead, we are having all these questions about how do we provide TA and training to clinical providers on the role of the peer supporter. And so I say, wait a minute. So you're paying the providers to do something out of their scope of practice. So they're getting paid to not do it correctly. And then you're paying TA and consulting to come in to teach them how to do something that they shouldn't be doing in the first place, right? Is that what I'm hearing? And I use the example, I'm a peer-run organization. You don't want me to hire psychiatrists. The last thing you want me to do is hire a psychiatrist for a million gazillion different reasons, right? Why are you having psychiatric settings hire peer workers? Okay, so that was my little soapbox. In saying that, there is absolutely precedence for what you are talking about. Here's the thing with the organization. So many of these organizations are getting funded to include peer supporters, or they are getting pressured by their funding to hire peer supporters, but they don't know how to do it. Part of our in with providers has been, if you're working with folks coming out of prison, you need a workforce of people that have been in prison. You need to be employing those former gang members. And that at that point, their eyes glaze over, right? Because that's what peer support is for somebody coming out of a prison. They are so fearful, have so many structures in place to not employ that workforce, that we come in and say, oh, you don't have to worry about that. We'll employ them. We know peer workforce, we know peer support. We'll do a subcontract with you and we'll do the peer support component. So that is part of the arguments that I have been able to make with other services and other settings. They don't know how to do it. And so the other thing that I have proposed to providers as they're thinking about hiring peer workers is minimally, if we start out by providing peer support, but do the mentoring and the training and technical assistance for you to be able to make an informed decision about whether your organization has the capacity, the culture, the structure to be able to utilize peer supporters. We already have the peer support component, but you're making a decision based on something that you're not even familiar with, you don't know. So that's the other in we've been able to get, is provide them with training and technical assistance so that they can determine whether they can do this well or not. Mostly they say no.
So it's so powerful. And I think another component to that too is that's why they view peer support as so radical, even though it exists in a lot of different spaces. And the idea that, yes, we flip that narrative once again with the idea that, yes, we have value through our life experience. Through my work with the United Nations, they've often said, like, we bring you on for your life experience, your lived experience, not your expertise. You don't have expertise. And I'm like, I beg to differ. I do have expertise, right? My life experience and your life experience inform your expertise. I actually like to think of it as lived expertise, right? These ideas
Yeah.
of professionalism that we get caught up in, right? That really
Yeah.
take away from a lot of that, right?
That's right. And there are ways to have these conversations, right? So like one of the examples that we do when we do training for providers is, we have them imagine that they are in a hospital room and they were just diagnosed with cancer, whatever form of cancer. And there is a nurse that walks in, you have your doctor, you have a social worker, and then you have a person that was laying in the same bed that you were in a year ago. What are the types of things that you want to know from your doctor, from your nurse, from your social worker, and the person that was lying in the bed? And then we compare those, right? So sometimes we have to take things that feel more familiar to people, go from the unknown to then take out the mystery. And typically the questions they want to know of the person who is lying in the bed is, what was it like? How did you overcome the grief and the loss? How did you decide what treatments? How did you deal with having a colostomy bag and keeping it clean? Like all those practical things they're coming up with to ask the person that had been there. And so then they're able to go, when we're starting to talk about the role of a peer supporter and why it cannot be replicated by a clinician with lived experience, by a case manager without lived experience, like why it cannot be replicated. You can't make that up. I can't say, well, I can only imagine what it's like to be in prison, And so when we start those types of dialogues and start exploring it with people, we typically see the light bulbs go off in terms of understanding. In saying that, most of the providers in our state were funded before any training was available. So that shit got co-opted immediately. Now we're having to go back and try to undo the harm that's been done.
Wow. Wow. There's so much in terms of thoughts there. I do want to uplift something in the chat. An amazing quote from Cherene. You cannot order peer support, right? That's just so good. Put it on a t-shirt, put it on a mug, do whatever you have to do. So I see Heather, you have your hand up. You want to ask a question?
It's kind of a little more like a statement. I'm in Scranton, Pennsylvania, and like I know at one point in time, I don't know if it's still in place, but talking in terms about having like peers in the court system and different things. I know that in our court system, we had at one point like a mental health court. And what that was supposed to do was individuals who had mental health issues, that was supposed to help them, but they still have never had, to my knowledge, had a certified peer specialist or anybody like there to support. But like on the other hand, when we had a big initiative a few years back where there was a huge call for recovery specialists, they then implemented what they call in our area drug court, and they have a certified recovery specialist who work in that system. But there again, there's like issues with that because you have to have a 4-year degree. It doesn't matter what it's in, but in order to work with individuals, like they're saying in the court system, you have to have a 4-year degree. Which then demeans the fact that, okay, so I don't have a 4-year degree, my worth isn't anything in this system, so why bother is the thing that like I come up against often with mental health as well as court, as well as you name it, anything. Obviously, I'm sure a bunch of us come like just hit that brick wall of we're not enough, or we're not, and like, I mean, but on the other hand, there were initiatives that were done that in the prison system itself, because I worked alongside with like 4 individuals that became certified peer specialists in incarceration. Sorry, it was a little so while they were doing their time in the jail system and the judicial system, however you want to word it, I don't know, they were getting trained to become peers. So I mean, there are some things out there that are in place, but I think it kind of goes back to like what you were saying, Cherene, where are there really teeth in any of it? Because if it gets to a point, I know even the facility that I work for, after the 5 years runs out of the, the funding that they get for the 5 years, that program's just basically thrown to the wayside. There's really not anything. It's like, oh, we'll give you 5 years of budgeting for the peer program. Well, then after that 5 years is up, that money is gone, dried up. So they just move on to the next year thing that'll give them 5 more years of money and just drop it and don't really invest in any of the stuff. And it makes it a very difficult thing to get forward in any of it. So sorry.
Heather, and on the funding side, do you mind if I respond to that?
No, go right ahead, please.
On the funding side, that there was when we started, we had to be underneath a behavioral health agency. So when I share the horrors of you want to be a standalone PRN organization, it is from my experience of several years being underneath a behavioral health agency. And long story short, not only did not align with our values, they were embezzling money.
Yes.
And as a reason, and we were the whistleblowers on it. So it was a mess. Yeah. When the FBI and the SBI came in to investigate, all the funding for that organization ended up being pulled, which meant that our contract was pulled as well, which meant that our funding was in jeopardy. We could have easily gone away just by affiliation with the organization that we were the whistleblowers on. The community felt we were so relevant and so impactful that they gathered and went to the funders and influenced outside of me and outside of us, influence them to keep what we had in place. And so I say that because sometimes with these types of things, my question becomes, are you relevant? As a PRN organization, how relevant do you feel to the community? If you're just another program and there is no connection in that way, you can come and you can go and money will be added and money will be removed. But if you're a fabric of a community, people are going to be pissed if there is a risk that you're going to go away.
I love that. I love that addition. It's so important to think again about these PRN spaces as more than just programs, right? Like this idea, because that's often what happens in the mechanism of the system, right? In the market, we're thought.
That's right. That's right. And on a bigger scale, we bring attention to our community. Mm-hmm. Every time we get publicity, every time an article is written about us, every time we end up going to, I don't know, federal meeting or get an award, it brings attention to what our local community did to invest in this alternative. It's a win-win from a political perspective as well.
Yeah, thank you, Cherene. And I see Katie, you have your hand up, but also Kim, I think you want to say something.
Yeah, I just wanted to let you all know we've got about, I think, 8 more minutes. I know, and we can, go further a little bit if you want. I know that we're gonna have a little break before we go on, but I just want to be aware of that. It's totally up to you all. And then, of course, it'll be, getting back to your question, Vesper, about making sure that we're having a goal, and then what does next steps look like, and we'll work on that tomorrow. So I'll let Katie go ahead.
I am so honored to get the opportunity to be here at Alternatives for my first time. I'm in Sacramento, California, and I found peer support about 5 years ago. And, the only reason I'm sharing a little bit about how I came to peer support is because I was fortunate that part of my story was that I was able to go to college and get a degree and then go to graduate school and wanted to become a therapist. And what was underlying that was I want to work in mental health because I feel like I was given these cards for a reason and I want to help other people. And so becoming a therapist and a drama therapist, that is what I felt called to do. But then when I was in therapy school and, I just had constant barriers of, don't share your own experience. And I was like, but that's the whole reason I want to do this, like, obviously not to make it about me, but to say, like, the reason I want to help you is because I wish somebody would have been there to help me. So long story short, feeling like I failed out of therapy school, I took an alternative track. I got my MA, but it was in psychological studies, and I was up in the air for about 8 years, feeling like, where do I land? Like, yeah, I have these degrees, but I'm not going to get my license. I struggled a lot with staying employed. I bounced from job to job, and by the grace of the universe, I discovered Cal Voices when I moved to Sacramento in 2018, and I signed up for their peer support training. So I went through my peer support training, after 10 plus years of medical model mental health work. And it's because of feeling like I hadn't found my niche. I hadn't found my place to really belong professionally and personally be able to share my lived experience, that I am so impassioned with making peer support valued, like not just valued for what we do for each other, but valued in the sense of, it is just as powerful as a license. It is just as meaningful. The training is just as credible. So, and I'm in California, so there's this big rollout with peer certification, and I'm so concerned about, what's happening with that. And I guess, I just overall, I guess I would want to ask, how do you think I could leverage that to my advantage in my county and in my state?
Can I just point out that you actually have a distinct advantage, believe it or not. So not only do you have your lived experience, but you have been trained in the ways of the clinical world. I have that advantage, right? So I learned about it from the inside out, but I also was stuck in working in behavioral health settings for many years before I started a PRN organization, with that dissonance, that disconnection between my heart and what I was seeing. But it was also, I learned the most about the problems of clinical practice and behavioral health settings by working in them and being able to learn the language enough, learn the structures and the systems enough to be able to use that against them. Yeah. I mean, that's part of the reason why I've been able to get a peer organization with some validity in our community is I can't go into a meeting and they're spewing this bull crap, this clinical bull crap. I know how the systems operate. I know how they're funded. I know the service definitions. I know our Medicaid plan. I know how you're being trained. I know what your licensure says. I have a distinct advantage when I go into those spaces because I can use that knowledge that I have to then change, to flip the scripts, right? So you actually, you know, Vesper and I've talked about, we all have privilege, just in different ways, in different places, in different spaces. We have some sort of privilege that we show up with. That's a privilege that you have, that you become dangerous when you also know the systems, but you're working toward an authentic recovery and peer space. You know a little bit of the secret sauce. I'm, you know, it is true. It's one of the secrets of how I've been able to do this for so long. Don't talk to me about how inpatient settings run. I know how they run. I worked in them. Don't tell me about, you know, well, based on our ethics and you know, you have to have a duty to warn. Bullshit. That is not true. You do not have to inform anybody when somebody has thoughts of suicide. You actually have to support them through it, right? That's literally what you do for a living, is support people through emotional distress. So let's look at the statutes and let's go back to it. Oh, the truth is you're at risk of your fear of license. Now that's a totally different thing. That's not the same thing. So anyways, I say all of that because you can show up in conversation in a different way, which is an asset to the work that we all do.
Appreciate it very much.
I call it utilizing your superpower. and a lot of people are sitting on it. They're sitting on it.
Yep. Yeah, no, you're dangerous, Katie.
Just learning how to be, I guess.
Well, that's why, you know, Vesper and I spent so much time today about showing up in different spaces and figuring out where your space is, but just show up. I'm more concerned if you're clinically trained and you don't realize that what's happening is harmful, but then you say you have lived experience. That's very concerning to me. But you're clinically trained and you see the crap that's out there, and you have lived experience, and you're willing to show up to counteract that. That's some power right there.
That's awesome. Thank you.
Such a powerful note for us to end on. I know we're at time. I just want to thank you all. Thank you, Cherene. Thank you, Kim. Thank you, Judine. Thank all of you for your reflections, just everything that we've talked about. It's been a wonderful action group.
Oh, it's been wonderful, Vesper. Thank you. Yeah, I mean, I don't know about y'all, but I think we're in the best action group. This has been some really good stuff. Cherene, thank you for dropping your knowledge, sharing your experience, helping just to just ignite people, you know, and remind people it's possible. Because I think some people, they've got these dreams. They're like, oh, I can really do that, you know?
Yes.
Yeah.
Yes. If you see it and it's problematic and there's a gap and there's a need, change it. That's what I keep coming back to. Do something about it. Change it.
Absolutely. And connect and educate and talk and all this stuff. Get you a mentor, somebody who's already done it.
That's
Don't
right.
have to reinvent the wheel.
Nope.
And you don't have to feel alone, whatever that is. Connection is huge. Everybody, thank you. It's been wonderful. And I know tomorrow, Vesper's going to be leading us into our goal and then our action and what that's going to look like, so we can walk away and feel good about these conversations. So think about that. In the meantime, we're going to get a little break. And if you want to hang out with me later on to kind of talk a little bit and make some connections, but you got other groups to choose from as well. And if you just say, hey, I need to take care of self and do something else, you have options. Alrighty, in the meantime, thank you. We miss you already. We'll see you tomorrow. Check us out tomorrow, y'all. We got one more day. One day. One more
Thank
day.
you. Bye, everybody.
Thank
Be
you,
well.
Sherry. Thank you, thank you, thank you. Thank you, Vesper. Adam, thank you, Adam. You rock, my friend. Thank you, Judine. Thank you all. We'll see you soon. Enjoy your evening.